Hi, I'm Leslie Mendoza Temple, speaking on the topic of medical cannabis, a time for reassessment for the comprehensive review of pain medicine. It's a short introduction to myself. I'm a family medicine physician who is also trained in integrative medicine and realized that using medical cannabis may be an important tool in my toolkit. So I became uh, self educated on the topic, culminating into uh, a role with the Illinois Department of Public Health as the chair of the Medical Cannabis Advisory Board. I have certified over 1,200 patients since 2015, with about 800 patients actually getting the card and giving me feedback because much of what I'm going to discuss today has been from hard earned knowledge, but also we will be doing a dive into the literature and hopefully helping impart to you the basics of cannabis, how to recommend it, and what are some of the legislative policy issues around it. I have no disclosures. And so, for our objectives specifically, we're going to talk about cannabinoids for pain. We'll share a few cases, but we're not just going to talk about pain. Going to talk about um, also the downsides of cannabis, including cardiovascular risk, cannabis hyperemesis syndrome, cannabis use disorder. We'll talk about challenges in terms of patients procuring medical cannabis and how to guide you on general uncertainties regarding this substance. We'll provide regulatory updates, as I mentioned, and we're going to share ways to help promote healthcare professional involvement since this whole field is still very much evolving. So, cannabis is a very complex plant. Everybody knows about, or most people should know about THC and CBD, with THC being the psychoactive, or we would say the intoxicating part of the plant. CBD is well known for its role in helping with inflammation and perhaps calming the nervous system down. It helps temper the effects of THC and its intoxication properties. But those are only two of 120 plant cannabinoids here. And I'm sorry, this slide's a little bit fuzzy, but this is what the knowledge base is regarding how they act in the body: CBD, THCV, CBG, CBC, CBDA, THCA, and CBDV. There are probably more. This does not obviously fit, this circle does not fit 120 cannabinoids, but we are really on the cusp of just beginning to understand what this plant can do, which also makes it extraordinarily difficult to study because it's hard to standardize the same thing over and over again when you get so many different combinations. Short clarification: marijuana or cannabis is a plant that can be defined from a regulatory standpoint and an intoxication standpoint by the amount of THC that is in the plant. Marijuana, or we would say medical or recreational cannabis, can have anything over 0.3% THC, according to our US government standards. From a psychoactive, intoxicating point of view, it definitely can have that effect. But hemp is grown, must be less than 0.3% THC and not have psychoactive or intoxicating properties. But they are both from the same exact plant, Cannabis sativa. And what's confusing about this is that you can buy hemp pretty much anywhere thanks to the Farm Bill. And that's where you're going to see products like creams and oils and capsules with a cannabis leaf on it, and it's confusing. But those products are not supposed to be intoxicating due to their trace to no amounts of THC. So we're really going to focus on the cannabis from the greater than 0.3% THC category. I don't really call it marijuana, I call it cannabis because that's the name of the plant. But this is actually from the government website in New Jersey, it was a nice pictorial of differentiating the two. Okay, so we're going to talk about the left side of this box mostly. Cannabinoids or cannabis is also composed of many other plant substances that give its aroma, its flavor. There are so many non-cannabinoids that also can have biological effects on the body. And they often have an aroma. So they give the cannabis its characteristic smell like skunk or lavender or citrus or pine. And myrcene, beta caryophyllene, humulene, limonene, these particular terpenes can also have a physical effect that we need to study more. But I'm going to focus more on what a physician or advanced practice provider may need to know, because this is probably kind of a next level thoughts, and we need a lot more research to delineate how combinations are going to act in a person. But there's a lot of research in this area emerging. So regarding an evidence base, a think tank of scientists and clinicians got together with through the National Academy of Sciences to create a I guess a not best practices, but a state of the science compendium of the health effects of cannabis and cannabinoids. We do know a lot about the toxicities, addiction, and other issues regarding substance abuse through the National Institute of Drug Abuse, or NIDA, where the funding, our government funding, goes to research substances for their deleterious negative effects. But this actually is about health effects, the therapeutic properties of cannabinoids. And this was created in 2017. So it's a very neatly packaged evidence base. It's available for free online. It doesn't have really nice and neat ways to dose and how do you clinically deal with that. That's what we're going to talk about today. But I will present to you the summary of this neatly packaged evidence base. But keep in mind, I'm speaking in November of 2024. So this is already become a bit old, but it's still valuable. So the think tank consists of all academics, all highly esteemed physicians and researchers in the field of multiple specialties here, all peds, adult medicine, OB-GYN, neuro, you name it. So this is a pretty stacked group that got together, and they came up with different categories of evidence for cannabinoid use for treating certain conditions. So the conclusive evidence was for chronic pain, chemo-induced nausea and vomiting, and the spasticity from multiple sclerosis. So this box was literally taken from this document, and I think this was an important one regarding chronic pain, because we are still dealing with an opioid crisis, and so to address that, to have another option is important. But still, how do you recommend it? What is your patient supposed to take? We will go into that. But we also know about dronabinol or marinol, which is for the treatment of chemotherapy-induced nausea and vomiting. And then for MS spasticity, there are pharmaceutically obtained cannabis products, notably Sativex, to help with multiple sclerosis spasticity, but it's not available in the US quite yet. Then we have moderate evidence. So downgrading a bit the evidence from conclusive to moderate, they found it for sleep, particularly short-term sleep outcomes for people who have sleep apnea, fibromyalgia, chronic pain, and multiple sclerosis. Clinically, I have found it useful for sleep, especially my older patients who really don't want to use the cannabis other than to help them sleep. It's a very viable option, and it's nice to know that there's moderate evidence and that it's building since 2017. Some studies are negative, but in the end, sometimes you just have to try different things with your patients. But you do have a leg to stand on if you're trying it for sleep. And then limited evidence, again, older evidence here. So I'm sure that new things have come up for increasing appetite and decreasing weight loss in HIV/AIDS, for MS spasticity, for clinician measured symptoms, for helping improve the symptoms of Tourette's, reducing anxiety symptoms in people who have social anxiety disorders, and improving the symptoms of PTSD. but these are going to be very small trials. They're not at all conclusive at this point, but it's nice to see that there's research in those directions that may be promising. So I wanted to update this group since 2017 because we can't just rest on that evidence base. So I picked one area since this is about pain, and there was a systematic review of randomized placebo-controlled trials that was published just in September 2024 in Curious, looking at 5 randomized controlled trials for fibromyalgia and neuropathic pain. And compared to placebo, they found that cannabinoids provided significant relief from chronic pain using the VAS, and that the patch or the cream of CBD led to a more pronounced reduction in sharp pain, according to the neuropathic pain scale. Minimal to no side effects were recorded, which is really important because this is where, as an integrative medicine physician, I'm probably more willing than others to try new things that are out of the box for my patients, because if it's safe and relatively affordable and doesn't have any big red flags, I'm more willing to try things for my patients who are still not seeing the results that they need to see. So when it has low side effects, that makes it a lot easier to work with. But I will definitely go over side effects because this is not a risk-free type of substance. So taking those 5 randomized controlled trials, when I look at this as a clinician, I'm like, how is this going to help me? All 4 of the trials said that neuropathic pain was improved. Well, that's great. What did they use? They used THC oil under the tongue. There's topical cream. There was an inhaler with THC and THC oil sublingual from Weitzman et al. In Israel. They used actually pretty much the same substance in those 2 trials, as well as a THC CBD combination, a very low amount of CBD. And they compared them to placebo and came up with these doses, which I think is very interesting because, just FYI, if you're using 14 milligrams of THC for a 70 kilogram person, I would never start with that much. I would start with 2.5 milligrams and ramp it up. But it's nice to know that people did experience improvement in the trials at these doses, 14 mgs of THC, which really is so individualized. So you don't have to hang your hat on these doses to start people, but know that you can ramp them up. The other thing I thought was interesting with the CBD cream was that it was applied 4 times a day. So that's important to note because some folks feel it helps or they're not sure, and you have to put it on multiple times. So I thought those were important things to point out in these trials. How does cannabis work on the pain and the brain? So there are multiple places it works. We have CB1 receptors throughout the body, but primarily in the brain, where THC particularly works. And researchers have identified the anterior cingulate cortex as having a downgrade in activity, which helps reduce the pain signals that happen. So when that's downregulated, pain is more tolerable and manageable, as well as downregulating dorsolateral prefrontal cortex activity. And I know those are only 2 areas. There are several others, but I thought that was sticking out to me more, where you can actually spot the areas of the brain where you'll see cannabis, like after you give it, you can see decreased activity happening there. And this is something my patients tell me a lot, is that they feel more relaxed and that the pain doesn't seem to have the same amount of drama it had before. And I think the relaxation response is from promoting parasympathetic activity. So when that increases, a lot of other things improve, including digestion. So really, cannabis has a lot of other properties besides managing pain. So I wanted to bring a case up here of a complex patient, someone that you might be encountering in your practice regularly. We have a 75-year-old man of South Asian descent who has AFib, depression, diabetes, bad back, and burning feet. He's on opioids, he's on gabapentin, fluoxetine, diltiazem, a major blood thinner, warfarin, lisinopril, aspirin, metformin and B12 daily. So he's getting standard of care stuff pretty much from his primary, but he complains that the medications make him constipated from the opioids, sleepy and foggy brained. And he may have other things because of the diabetes with slow moving digestive tract. A lot of things can make you sleepy and foggy brained just looking at his medical history, but the meds too definitely can contribute. So how much they contribute, it's hard to say, but he's also, I forgot to mention, not sleeping well. Um, so he's had 4 epidurals in 7 years. He tried. He can't get more of them. He gets as many as he can in the amount of time allowed. He's had many rounds of physical therapy, and he was offered surgery but declined. And he's been doing his integrative therapies like acupuncture, chiropractic care, and massage therapy, but they're intermittent. And because they're typically not covered by insurance, the finances and transportation requirements would limit his ability to get these. They would provide temporary relief, and I encouraged him to continue, but it's just not enough to manage all that he's going through. So with this patient with a bad back and burning feet, feeling pretty yucky most of the time, what would you do? This is a cannabis talk, so we're going to obviously talk about that, but he's got a lot of meds on board. What about the value of pharmacogenomics data on him? What would you actually tell this patient to do? So I'm going to go through these points specifically. Pharmacogenomics is something I've been just starting to get into, but I don't usually use this as a way to like figure out what to pick for my patients. It just helps explain, hey, here's a person who may be real sensitive to the substance, and here's a patient who might need a lot more of it. But you usually find that out on the back end. With cannabis in particular, they are being processed by the cytochrome P450 enzymes in the liver, and poor metabolizers will increase the amount of THC and CBD in the body, meaning the CBD and THC may feel more effective, but you can also feel more side effects because those substances are still being present in the body. They're not being broken down, they're being poorly metabolized. And that we find to be the CYP2C9, 2C19, and 3A4 cytochrome P450 enzymes. And those who have poor or immediate or intermediate metabolic activity tend to be more sensitive, maybe more sensitive to cannabinoids in particular. Things that actually decrease CB levels, which would be a rapid metabolizer, these are the folks who don't feel anything. They're like, this stuff doesn't work. They maybe need to take more. So just to remind you, poor metabolizers are folks who are going to feel the more toxic effects of the drugs. Rapid metabolizers are not feeling the effectiveness of the drug as much. So you have to adjust. This patient's pharmacogenomic profile shows that he's a poor metabolizer at CYP2C9. So you could predict maybe that he's going to be real sensitive to THC and CBD, but also keep in mind all the other medications he's on. He's an intermediate metabolizer of the 2C19, and he has normal metabolism for CYP3A4. So think of these 3 enzymes as more cannabis oriented. There are others, but this is what seemed to pop up the 3 the most in the literature. So what would I tell him to take? And actually, without even knowing his pharmacogenomic profile, often I will, almost 100% of the time, in a cannabis naive patient, I'll start him at a really low dose of like 1.25 to 2.5 milligrams of THC with any amount of CBD. And I'm going to go over like how you do that with an edible or a topical, not a topical, an edible or a tincture. Regarding topicals, I'd recommend that he put a thin layer of CBD only hemp cream, or he could go with a CBD and THC combination in a 1-to-1 format and put it on anything that hurts daily. And remember that one research trial I showed you, they put it on 4 times a day. Most people aren't going to remember to do that. This stuff is expensive, but I still have people who put it on once a day, and either type of cream, and they seem to feel an effect. But if they don't, that's really it. Have not to this day had anyone feel worse using the cream. It's just a matter of whether it works. And to this day, I still have not found anyone who felt intoxicated while using the cream. So this patient who's on blood thinners and opioids and diabetes medications, an antidepressant, fluoxetine inhibits CBD metabolism at the CYP2C19, which he has. He's a poor metabolizer, so he may have more CBD side effects. And I forgot to mention he should have THC side effects. So just being on fluoxetine might increase his cannabis response. Diltiazem also, he's on both of those, so that may increase the THC and CBD through the CYP3A4 pathway, and then he's on a major blood thinner, and CBD can inhibit Coumadin or warfarin metabolism through the CYP2C9. So your INR can go up. He's maybe at a greater risk of bleeding. So whenever anyone's on Coumadin, I'm really nervous about that. I might just do creams only for someone like that. And then for the opioids plus gabapentin, you just those two alone, doesn't matter what your cytochrome P450 profile is, they both can add CNS depressant effects. Then you throw in cannabis. So you just have to be mindful of that. But if the patient's like, I've been on that combination forever and I'm feeling okay, I mean, he's tired, he's not feeling okay. But if you add cannabis because he's just at his wit's end with pain, then it's worth a very careful trial with the ultra low dose THC. So I thought I'd throw in my pharmacogenomic profile, and it shows that I have several things. I'm Asian, Filipina, and interestingly here, I found I'm a poor opioid responder, and I'm remembering a time when I took an opioid after a procedure and immediately wanted to throw up, almost did, and felt horrible for quite a while. But in particular, when it comes to cannabis, I am a poor metabolizer of CYP2C19. And in my previous experiences with cannabis, I just want to sleep. It's not, I feel dizzy on it. I don't feel myself good on this. And maybe it's because of my body's slow breakdown of the substances. I also found that I'm really not capable of breaking alcohol down very well. And I know that I have uh, an abnormality in my alcohol dehydrogenase genes, and I turn bright red. So I'm just that person who's super sensitive. And now it's kind of nice to have this validate that it's not all in my head. It's my liver is just not breaking these things down very quickly. So I have to keep that in mind, and that there are really heredity, race, all of that is involved here in propensities to have cytochrome P450 abnormality. So in our patient and myself, who's from Central or South Asia, and also I'm East Asian, our patient is South Asian, we have a high propensity for reduced CYP2C19 variation in our liver enzymes. So that's definitely me. And I have objective data that, yep, I am a 2C19 reduced. So I'm going to keep that in mind when I'm recommending cannabis to someone like me or to this patient. But it's generally, you're not going to have this kind of information. You don't have time typically in a short visit. Always go low and slow. You can always go back to that prescription of the ultra low dose THC to start with. And then you increase it day by day to the tolerable maximum effect. So when in doubt and you don't know where to start, I believe topicals are nearly always worth a try. Of course, there's skin allergies or sensitivities someone can develop, or if the smell of the cream is, not pleasant. These are all pretty minor inconveniences. You would stop the cream if you were irritated, but because this is so expensive, you really don't want to, waste a person's time on it. I think having a jar of the cream around for any body part that hurts, you might find that it's useful in some places, some joints, and in other places it doesn't work at all. But that also means a patient needs to just try the cream anywhere that they want to try it. Whether it is from a more psychoactive formula with a higher amount of THC, or if it's just from hemp. It has only CBD in it. I am still not sure which one is best for patients. The act of putting the cream on a place that hurts, I think, also has a lot to do with the therapeutic effect or the placebo effect. But why not give it a try? It's very low risk. Okay, so here's another case. This is not about pain, but this is about interactions. In the chronic cannabis user who gets an infection, a urinary tract infection. So we have a 48-year-old woman who uses cannabis, medical cannabis nightly for her chronic low back pain and insomnia. And she's been tolerating it well, using it appropriately, but she's got a UTI, uncomplicated. And so she was started on sulfamethoxazole trimethoprim twice a day for 7 days. And she's had this antibiotic before when she's had UTIs, which can happen in women, especially this perimenopausal woman. No side effects in the past, but she gets dizzy after 3 days of treatment. She's not really doing anything else but this new medication, but she was also using cannabis as usual. Wow, how do you explain that? Well, in this antibiotic is metabolized by the CYP2C9 enzyme. So when you have decreased THC metabolism, it's going to float around in the body, and then you have the risk of the intoxication and toxicities of the THC making her dizzy. So she was probably on higher amounts of THC than she normally would take in. But when it comes to going on a new medication, uh, you would want them to stop their cannabis and just be on the medication, finish the course, and then resume when ready. And remember, these three enzymes are primarily in the cannabis metabolism space. There are more, but CYP2C9 inhibitors include common antibiotic, common anti-candida, anti-yeast medications, CYP2C19. These are common as well. Proton pump inhibitors, antidepressant, SSRI, fluconazole, fluvoxamine, another antifungal medication. And in the CYP3A4 inhibitors, we got to watch for the blood pressure stuff. And again, ketoconazole, which seems to be everywhere in terms of messing with inhibition. And then HIV medication. I'm sorry, not HIV, sorry, COVID-19 medication. So you just have to be really careful. When in doubt, just stop the cannabis, have them take the medication they need. Usually it's not going to be forever. But if you have someone on long-term diltiazem, then you've got to go and you really think that cannabis will help, just have them take really small doses and then look for incremental improvement. And if they don't tolerate it, then stop it. But this is for this patient who doesn't have a whole lot of other options for pain. This is someone I would still try cannabis with very cautiously. I want to credit a lot of the slides about pharmacogenomics to my colleagues at Mayo, Jessica Wright and colleagues who created a really great article on this topic. There's a lot also on PubMed, but they summarize it very nicely here. So you can use the QR code. It is, you have to find this on page 32 to 35. So you're going to see the whole magazine from Mayo if you want to look at that. Okay, so what about all the different routes? What about cannabis? How there's many different ways to get cannabis in your bloodstream. Edibles, very commonly used and available. It's great. It doesn't go into the lungs, so you don't have to worry about that. But it can take an hour or two to kick in, and it can last the whole evening, which is why it makes it great for bedtime use. As for people, especially who are not sure if they are good candidates for this, they're nervous about it, if they have insomnia, obviously, or if pain is waking them from sleep, or if they have anxiety and they just can't seem to calm their minds. An edible is really nice. But I always tell them, wait a while before you decide whether you're going to redose. This is where we get into trouble when people don't feel an effect in the next 5 minutes and they take a second edible or a second brownie, and then 2 hours later, they're flat on their backs, feeling really, really weird and bad, throwing up, feeling strange. So edibles can get you into trouble because of this delayed onset. But if you use that to your advantage, let's say a person has trouble, they wake up in the middle of the night, and maybe you take your edible right before bed so that it's kicking in right around the time they would start to rouse, and then hopefully keep them down or have them fall asleep more easily if they woke up. And the fact that it acts longer typically is nice for that long-term use. Its downside is if you have an edible that doesn't sit well with you, then you're stuck with that feeling until it wears off. With tinctures, this is somewhere in between smoking and taking an edible. So you put the drops of cannabis oil on the tongue, and it may take 15 to 30 minutes to kick in. I forgot to mention here that RSO oil, which is a very high concentration of cannabis extract, that one also works relatively quickly. It's really concentrated, and I usually don't recommend RSO oil for beginners. Smoking and vaping, this is something that's obviously commonly used. Its benefits are that it works quickly. So immediate gratification, immediate sensation. It also tends to leave its influence in a faster fashion. Problem is, obviously, we're dumping in pollution every time you take in an inhalation, whether you're smoking or vaping the flower or vaping the oil. I'm not a fan of vaping the oil because of the uh, issues that we've had with the lung vaping crisis and the vitamin E acetate that can impair lung function and injure them. So I'm just, but I realize that this is heavily predominant on the scene, and I'll talk about the risks of that later. We have suppositories. So this is something you'll see in a medical cannabis dispensary, or you have to make it yourself. From a rectal or vaginal point of view, the benefits are there's no taste. So for people who are super sensitive to the flavor and don't want to smoke, then there it goes. And I think maybe mentally, if you have tailbone pain or low back pain, vaginal complaints like dysmenorrhea, chronic pelvic pain, there's something about putting the substance closer to where the action is, maybe helps. But I don't have tons of experience with patients using suppositories because they're not super available where we are in Illinois. But the ones who have used it have pretty much felt they've helped, but they don't always have access to it. So many of them will make these on their own, but I don't have that many patients who use it because it's also no one really likes the idea of the rectal, especially, but it's an option. There's also the patch, which also helps solve the problem of the flavor and the taste, and you don't have to put it anywhere unpleasant. Half of a patch to a full patch placed on the forearm or on top of the foot where the skin is thin. That can be done every 12 hours. I have a young patient who has seizure disorder, Dravet syndrome, from having childhood cancer, and this is how she gets her cannabis, is through a patch. And they allow this at her school. So I think that's a very nice option, but a challenge in Illinois is that the patches aren't always available. So sometimes you'll have patients who will buy out a dispensary's entire stock because they don't want to not have it, and then it makes it hard to get. So I'd like to see that supply chain improve. And then I mentioned topicals, the creams, the balms, the lotions. A thin layer, I wrote twice a day. I should change that maybe to 4 times a day, but 4 times a day is typically not a practical thing to do. Unless you're washing your hands, you have to remember to put it on each time. What about starting somebody on anything that contains THC? Not the hemp products, not the CBD only stuff, but stuff that has THC in it. Quantity matters. So when taking a cannabis edible, there'll usually be chocolate squares, or it looks like a gummy bear, or like a jujube, one of those, just a whole piece of stuff. Cut it into 4 pieces. Do your best to estimate it. Take it at bedtime or an hour before bedtime, depending on when you want it to kick in. And then any intoxicating effects hopefully are slept off. And that's what also helps patients not feel so nervous about it. Like, who really cares if you're kind of high in the middle of sleep? But I would be careful for people who are super unsteady on their feet. They may wake up, and if they're feeling really off, you don't want them falling. So you got to keep in mind your audience. Also, when to start it. What day of the week do you start cannabis in a new person? Maybe start it on a Friday night if there's nothing much going on Saturday and Sunday, so that they're not risking their next day's activities feeling off. Because if they're still stoned or, like if they feel weird from it, you want to pick a day where they could just kind of rest and not worry about it. So Friday night's a good time to start. And then when it comes to other medications, separate their pain, sleep, or any other kind of psychological medications by at least 1 to 2 hours. This is not evidence-based. This is more of a common sense thing I've noticed. The longer you can separate the cannabis with the drug, the medication, the better. But sometimes people take things multiple times a day. So I actually lay out what time you should take this, what time you take this, what time you take this. The more concrete you are about it, the more reassured the patient feels, and you can have them spread out their exposures to these substances. And I keep their medication, their pharmaceutical doses the same because we're trying to look for an improvement in pain, an improvement in anxiety or insomnia. So I don't drop their medications or make them choose cannabis or opioid. I think that is a very unrealistic thing to do to our patients. Um, and if you do make them choose, you have to wean them down on the other substances before you start cannabis. But I have not found that to be really necessary if you're keeping close track of each other, using your portal and whatnot. The patient feels a lot of good support from you. Can again keep their medications the same, just make sure they're taken separately, and you start the cannabis at the lowest dose possible. That's definitely the art of medicine. And then when ready, let's say the sleep has gotten much better, the pain meds are better, levels are better, then you can start tapering the pharmaceuticals down, and see what cannabis is doing um, more potently versus the pharmaceutical. Because most of my patients want to get off of their meds. And the way we do it is prove that you feel better first before we start chopping your medications. Sometimes you can't, and you have to just rest with it. But I have patients who have been able to stop their benzodiazepines and their opioids because of cannabis completely. But they also have like really strong desire, motivation. There's so much involved with that. Um, and I also combine integrative therapies with that to help them bridge that gap. So, other practicalities in initiating THC is generally let the THC drive your dose. I'm not so concerned about how many milligrams of CBD there is. It's THC that's going to determine how really the side effects of intoxication, the munchies, even fear, paranoia, anxiety, because the higher the THC there is, the more those things can happen. The starting dose for the newbies, I mentioned again, 1.25 to 2.5 milligrams of THC, plus whatever CBD is coming with that. And you can see that when your patient is purchasing cannabis from a dispensary, because it'll say, this bottle has 100 milligrams of THC in it, and it has 10 pieces of edible. So you know that there's 10 milligrams of THC per piece. Okay, if I want to give them 2.5 milligrams, I got to cut each piece into 4 little pieces. So help them do the math. And then when you're ready to go up in the dose, you could go by really tiny amounts for your super sensitive patients, like 1 more milligram a day of THC, or double it, 2.5 more milligrams that evening. And for the tinctures, we follow the same principle. You can see how much THC is in X number of drops. So it's always going to depend on how that formula was made. And this is where you can increase the number of drops every 2 or 3 hours following the previous dose. So if you give someone a microdose at 5 p.m. and they felt nothing by 7 or 8, it's not going to suddenly show up. By 7 or 8 p.m., if not much has happened, then you can take 10 drops instead if you initially had 5. And you just keep on building up the number of drops and having the patient write everything down so they can figure out what their dose is. It's very that's what's frustrating about cannabis is it's so individualized and it has so many nuances. But anyway, that's how I do it, and it seems to help my patients not have side effects or end up in the ER. So regarding safety, This recent article in the New York Times talks about the downside of cannabis because we know there's a lot of hype about how great it is and it's saving us from the opioid pain crisis and opening up so many possibilities, and that's great. But I see patients who have um, bad things happen to them, and when it comes to cannabis, but it really isn't. Um, Horrible, compared to like your opioids and your benzos and such. So we have to put everything in perspective, but we do need to have a very healthy respect for what cannabis can do. So this article in the Times was about patients who developed cannabis hyperemesis syndrome and other issues that kept them very sick for a long time. So we need to tell, here's this quote, why don't more doctors know about it? Who knows? Why didn't anyone ever mention this to me? Because um, this woman had really bad migraines and she was using it more and more, but it made her feel worse and worse. So with cannabis hyperemesis syndrome, the official diagnosis is it's after prolonged use of cannabis, um, there's episodic vomiting and it's relieved by stopping. There's really no other treatment, like, for the long term, but other treatments, like if someone's showing up in the ER or they're calling you at the office, "I feel nauseous, I don't feel good on this stuff. I thought this was supposed to help my fibromyalgia pain." One of the clues is if there's hot water involved, like for relief, hot showers, um, tummy, hot water bottles on the tummy. If that seems to help the patient, then you're probably onto something that they may have some form of cannabis hyperemesis syndrome. And that is because of the TRPV1 receptor that's activated by hot water. It provides some relief of the nausea. So that's one clue. Topical capsaicin or hot pepper cream put on the belly 3 times a day with gloves on so you don't burn your eyes when you touch your eyes. That can be helpful. Benzos, antipsychotics, these are things that are used in an ER setting, but as an outpatient, hot showers and some hot pepper cream can help, but in the end, they really need to stop using it. Oh, the other thing I wanted to mention too is that not all vomiting people who are in their 20s and 30s have cannabis hyperemesis syndrome. So, still you have to keep your radar up for other of the classic etiologies of abdominal pain and don't just blow it off as it's all cannabis. So, that's a definitely clinical judgment kind of thing. Then there's cannabis overuse syndrome, which I am seeing in some of my patients who already were using cannabis before they came to me to get certified. These are the folks, one of the clues is they use cannabis like, 4 or 5 times a day. They smoke it and it's just every day for a long time. But by the time we've had some impairment, and I have this listed here, you can read through. um, this is when you have to start thinking about what am I going to do for this patient who's overusing this and it's actually interfering with their life, with their occupation, with their relationship, and the judgment's not there. They're driving anyway, or they they use it even though it's making them nauseous because it's just there's a lot wrapped into this. And obviously seeing someone, an addiction specialist can be helpful, but weaning them down is key. So case 3 is related to all of this. The patient who smokes cannabis every day because edibles, quote, don't work. And this is a 52-year-old man who has fibro and PTSD. And he says that smoking joints are the only way that helps my pain and my anxiety. He often feels queasy. So you already have a clue there. And again, edibles don't work. So you can see him holding on to, I want to keep smoking this, but he's seeing you because he doesn't feel good. So I will always look at other ways to help approach his symptoms through integrative therapies, improving diet, acupuncture, and such. But then I will tell him some of this data that came out recently about heart disease and cannabis use. This came out a really large study, 434,000 adults, pretty much half men, half women, using either daily or an average of 5 days a month. And interestingly, smoking cannabis was the majority of how people used it, about 74% of the users in the study. And this kind of set us all a little bit on fire because it's like, oh no, is it all cannabis forms cause an increase in heart disease? And they wanted to say, well, is it different than smoking? Is it worse than smoking cigarettes or e-cigarettes? And they found that cannabis has a strong independent effect on the general population with cardiovascular outcomes, independent of the tobacco products and the e-cigarettes. But what I wish the study would do, we need more studies to say, well, what if you compared smoking slash vaping cannabis to people who take only edibles and topical cannabis, which is probably going to be more of your medical cannabis patient population. So I'd love to see them differentiate it because I don't know, is it the cannabis, the cannabinoids and terpenes itself that's causing more heart disease, or is it the smoke and something else? So we don't know yet, but I use this as an argument to tell my heavily smoking patients that you're increasing your risk of a heart attack or stroke. We need to switch you to edibles, topicals. Let's get into integrative med type of stuff. They're more motivated after I have this discussion in a very patient friendly way, non-judgmental way. Some other things to be wary of. This is obvious, but I really hate this when companies make cannabis products that look just like kids' candy. So check that out. In states that have cannabis laws that are recreational, especially, but recreational primarily means that they started off medical. Um, they have more ER visits from kids getting into mom and dad's stuff that they got from the wedding reception, so lock this stuff up and be very mindful. If you have kids in the house, you have to be mindful that they might look at your cannabis as something yummy. And the first thing that's gonna, uh, depending on how much the kid ingested, you could get hallucinations if it's a lot they took, but sedation seems to be more of the primary presenting problem when peds patients end up in the ER from an accidental cannabis ingestion. And then Delta 8 THC, which is a loophole. We find that you could buy that lots of places, tobacco stores, maybe the gas station, anywhere. Delta 8 is intoxicating. So just treat it like Delta 9. And the problem is that we need more regulation and actual enforcement to label these and keep them, behind regulated doors so that not just anybody can buy this. And look at this is also targeted towards children. This is a news release in Ohio. Okay, let's contrast that. I talked about all these risks, but let's look at wow, with opioids, you've got a lot of deaths happening on the rise over time since 1999, and in answer to opioids being used for pain management primarily. This is not, we always want to contrast this with our worries about cannabis. Yes, we don't know exactly what the effect will be on the patient, whatnot, but if you're super comfortable prescribing an opioid or a benzo to your patient, you should really think about cannabis. Because if you're willing to put up with these risks and these risks, why are you not looking at cannabis as a viable option? Oftentimes because it's very messy and it's the whole regulation part and what you're getting. I get it. That's what education's for. But in comparison to lethality and dependence among substance, take a look at the bottom left, and it's a whole other topic. LSD, psilocybin are actually on the low to very minimal risks from a dying from an overdose point of view. Low dependence, marijuana or cannabis does have a dependence potential, but from a lethal dose, we are not aware of many or if any deaths from pure overdoses of cannabis and no other substance. But you can also get in a car accident and die from a cannabis overdose. So, I don't want to ever be absolute. But then check out these other substances that have a lot more dependence to them and lethal doses. Alcohol, our legal drug, is terrible, dependence and lethality. And of course, you get higher into the opioids. I always like to point out caffeine is somewhere in the middle. You make your own decisions about it. Okay, lifetime dependence risks here also for comparison with nicotine at the top, down to heroin, cocaine, alcohol. 9% for cannabis. I've seen different figures for this, but the younger a person initiates cannabis use on a regular basis, the higher that risk of lifetime dependence can be. So when a patient tells me, I heard it's not addictive, I say, nope. And I point out my statistics. It's about 9%. It depends on when you started. So it can be addictive. And also another contrast of drugs that can have harm to oneself and harm to others. So think about also the impact on society. I think with cannabis, you're probably seeing some harm to others if people are driving under the influence, and that does happen, unfortunately. And that's why we need to educate patients that this is not some safe, get out of jail free kind of substance. You can slow your reaction time when driving, and that is a bad recipe for safety. And then we compare that with alcohol, which definitely can harm others and can harm the user. Moderation always, people. So anyway, some things that I've noticed in my own practice in Illinois, having had a program since 2015, what do we tell our patients? And this is the first day of the first dispensary that ever opened, and it's in January, a line around the block, people waiting to get into the dispensary. Um, so when you purchase cannabis, the labeling can vary because there isn't a federal standard really on how it's supposed to go because it's federally illegal. So you'll see all kinds of differences, but most of the time you're going to see the percentage of THC and CBD. And this is actually a formula that clearly is all THC and a little bit of this other cannabinoid called CBG. But this is someone who's going to have a very strong reaction. You would never give this to a beginner. It's flour, so this is a person this is gonna get smoked, or it's gonna be cooked into and made into an edible. But primarily, they're probably going to smoke this. So this is going to be for someone who is, um, able to take that amount of THC, not for beginners. But I'd love to see labels like this where you get a lot more detail, how much THC, all the cannabinoids, the terpenes and flavonoids, of course, the inactive ingredients, and the health warning, lot and expiration dates. You do get this in medical cannabis or recreational cannabis formulas in legal states, which is nice. Oftentimes they're really tiny, you can barely see, but rarely do you get a whole lot of this information. And this is the new International Intoxicating Cannabis Product symbol that is being adopted by several states. It was created by my colleague, Dr. David Nathan, at Doctors for Drug Policy Reform. So we're trying to really get some standardized labeling out there versus this Wild West that we kind of see right now. So other challenges you'll meet if you decide to certify patients is that in the state of Illinois, as recreational became the focus, I started to see a slow regression of low THC products becoming available in favor of higher THC products, which my cannabis patients, my elderly, fragile people don't want or need. So, this is a word of warning to those who live in a state where there's newer recreational programs where it was just legalized. High THC tinctures and edibles abound in the dispensaries in Illinois. So it's really challenging when someone wants that patch or just the very low THC formula. A lot of times they'll say, we don't have it anymore. And when a patient finds a formula they like, the dispensary says, we don't carry it anymore. You ask, when are you going to get it back in? And they're like, you get a shoulder shrug. So this is what's tricky. If you find something you like, I guess you just have to go there and buy a whole bunch of it because they might run out. The other solution is to DIY it yourself, and you can actually make your own 20-to-1 CBD to THC formulas by taking a drop of pure THC oil and mix it with 20 drops of pure CBD hemp oil. And you've just made yourself a 20-to-1, which is a very hot item in the dispensaries and kind of hard to find at times. So you can dilute or intensify the amount of THC as needed through your own dilution process. And other issues, if you live in a rural or underserved area, finding a certifying physician or APP may be difficult, and cost of services can be a barrier. Signing up to the programs themselves can be this pretty uh, frustrating computer. I mean, I spend a lot of time in my clinic helping people like upload their picture. I mean, but nobody else has been helping them. So the dispensary should help these patients, but you will probably do a lot more clerical things than you think you need to, especially having your staff do it. The other thing I want to note here is that cannabis flower is the cheapest way to get the product. And for people who can't afford very much, this is the only thing they can afford. So I never shame or, belittle them for smoking the flower. I give them the heart warnings and such, but the patches and the creams and the tinctures are quite a bit more expensive. So keep that in mind because none of this is covered by insurance and the patients are paying out of pocket. So, I always try and encourage them to figure out ways to maybe make their own butters, their own oils with the flour they have and not smoke it as much. Internationally and US wide, there are millions of people who are either in the states that are eligible for medical cannabis or recreational cannabis, totaling 208 million, and that's even outdated for the number of states that have medical and recreational rules. So you have to know this as a healthcare professional that patients have access. They're going to either hear about it, are interested, have a friend who's tried it, they're contemplating it, or they're using it. And worldwide, we also have countries that have completely legalized it, and that's continuing to grow. As of my literature search a few days ago, there are multiple federal cannabis laws that are in the hopper. They've either been proposed or they've maybe passed the House or just the Senate. So we'll see a lot more coming through or being rejected, just depending on when Congress can get to these bills. And then you have an opportunity to join your own state's health advisory board as a medical professional, an ethicist, or patient advocate, or other requested category. And another way you can influence policy is joining your own system's pain policy committee and also informing HR what you think. What if you have employees who are using medical cannabis during their off time? Um, Help influence that and also connect with industry leaders to influence wise marketing and manufacturing safety decisions. They may not listen to you, but at least if you can, please be the word of wisdom and sanity in a world where everything is about growth and making money. I really think we healthcare professionals have to extend our voices. So I actually became the chair of the Medical Cannabis Advisory Board for the Illinois Department of Public Health and have had multiple opportunities to try and influence policymakers on how to legislate things from a healthcare perspective. So please, it is a wide open field. You don't have to know a lot about it, but once you join, then you will learn. And I just chose Ohio as an example where there are opportunities to join their medical marijuana control program. And they even have on their website who they want on this board. And they have 8 members and they still have room for like more. And anyway, it's all volunteer, but it's something that's I don't think people know about as well. But you literally just apply probably through their website, and then you get interviewed. So you could actually have a really big role in your state. And every state has different requirements. Again, I'm not from Ohio, I'm from Illinois, but I'm giving a talk at Cleveland Clinic on this topic. So I focus, this is what you need to do in Ohio. You have to actually, other than having all the appropriate licenses, you have to do 2 hours of CME certified by their medical association or osteopathic association. And then you get this CTR license, and then you can become a certifier in Ohio. And as of last month, they have 585 in the whole state. So this also creates difficulty for patients who want this. And if their doc is not comfortable or is not certified, then they got to find these 585 physicians and try to get certified. Okay, so I'm very interested in the medical education component. So we have an article in press about, or not in press, sorry, it's an article under review for the Journal of Academic Medicine to propose how to teach medical students about medical cannabis, proposing competencies. The information will be changing a lot, but we have 6 core principles we want healthcare professionals to know, and I'd love for this to extend to nursing, pharmacy, and whatnot. Some resources here is a great book for lay persons and professionals, Medical Marijuana by my colleague, Dr. Kogan. There's also resources on cannabis and medication interactions that were shared by my Mayo pharmacy colleagues, as listed here. Okay, so take home point. When you start a cannabis edible, I'm saying this over and over again, don't consume a whole piece if you're new at this. In this picture here, cut it into 4 pieces and just take that little piece, one night at a time. So anyway, for this patient who is thinking about putting the whole thing in, don't do it. All right, I thank you for your time, and I hope that this presentation was helpful for you. Thank you.